Hello everyone, today we're going to talk about pain. You'll notice that I have 3 authors on here because I've borrowed slides not only from Dr. Mollenkopf but Dr. Kazachek as well, with their permission. The objectives are as listed, and there are many. The vocabulary is listed here for you to take a look at. There are many terms here. Some things which are new for you or perhaps not new might be partial agonist, tolerance versus physical dependence, serotonin syndrome, and hypertensive crisis, as well as salicylism might all be new things for you to review and be aware of for the test. Pain can be, as Dr. Kazachek listed, any unpleasant sensory or emotional experience associated with actual or potential tissue damage and described in terms of such damage. Key points, as she mentioned to you in Common Health, happens to be that pain is subjective. It can affect many other things like sleep, your thoughts, your emotions, your daily activities, and it's generally the most common reason why people show up in healthcare for acute medical care. When we look at the pathophysiology of pain, it's important to look at in a complete sense. Number one, there are lots of different things that come into play with the pain experience, including bradykinin, prostaglandin, leukotriene, histamine, and serotonin. And each of these all have a different role per se in terms of the pain experience. For instance, prostaglandins play a big role in terms of inflammation, and serotonin, as well as its counterpart norepinephrine, also play a role in terms of pain. Transmission can be affected as well. Here, somatostatin, cholecystokinin, and substance P can play a role. We also know that the pathways to the central cortex, the thalamus, can play a role, and then interpretation in the brain can lead to your sensory experience or your interpretation of the stimulation. So there's lots of different pathways along the pain experience. Hence, pain is not just one localized issue, but it's a systemic issue in how it's interpreted. Dr. Kazachek also talked about 3 main areas of the pain experience. So it can be inflammatory, it can be neuropathic, like diabetic neuropathy. It can be nociceptive, like trauma. So there are different types of pain, and these pain areas can intersect, as she mentioned earlier. Pain is very complex, as Dr. Kazachek mentioned. Not only are there 3 types of basic pain mechanisms, neuropathic, inflammatory, and nociceptive, but individual differences play a role in pain. Someone's age, their physiology, their personality, their culture, and then how the suffering is expressed by that patient. And that can affect some things like things of daily living, like sleep, their ability to work or not, how they function in a family. So suffering is definitely involved. She also mentioned the pain alphabet. This is something that the nurse really has a big role in. Number one, it's important that we interpret the person's expression of the pain quality. Is it sharp? Is it dull? You know, what region does it is it in? How severe is it? And the pain scale is good. What's the timing? So how long does it exist for? Is it associated with something? Is it associated with eating? What is it relieved by? Is it relieved by sitting down or lying down? What makes the pain worse? All these are factors in the pain experience. And this is important because the person's understanding of their pain and what makes it worse, what makes it better, where it is, will all come into play as to what might be something that we can give the patient to help relieve them of their pain. So let's talk a little bit about pharmacology. Our goals of therapy should make sense. One, we want to relieve, prevent, and make tolerable any sort of pain that the patient's experiencing. We want to quickly relieve acute pain, and in chronic pain we want to make sure that patients achieve their goal. So this might be, for instance, obtaining their activities of daily living, going back to work. Sometimes total pain relief is not realistic, but generally most goals are aimed towards restoring functionality. Drug selection. So this was something Dr. Kazanchik went over as well. The WHO analgesic level, the important thing is there are levels, but you don't have to always start on level 1, which is acetaminophen and NSAID. So post-surgery, they're not going to start by giving you Tylenol. They're going to give you opioids, for instance, after surgery. So here are some of the drugs that that we're going to talk about in terms of relieving pain. You'll notice that some are opioids, some are not opioids, some are agonists, mixed agonists. We're also going to talk about migraine therapy and gout therapy as well. So, in looking at a drug list in terms of non-opioids, we're going to start there first. Let's look at non-opioid analgesics as a main group. They differ from opioids in that they have a ceiling effect. So, for instance, if it takes one pill to reach an intended pain result or relief of pain, the thought is if you take 2 pills, it will work twice as good. That's not true with non-opioids. If it takes 1 pill to reach the max effect, taking 2 is going to increase its effectiveness. That's called a ceiling. Additionally, it has no tolerance, physical or psychological dependence. So you remember from nitroglycerin, tolerance is when the body requires more drug to reach the intended effect. Whereas physical dependence, if you take away the drug, then the body withdraws from that drug issue. We're going to talk more about this in substance abuse. These drugs also have antipyretic properties, so it can reduce a fever. And in general, not all cases, but the primary mechanism is through COX enzyme, which we're going to talk about, which prevents the formation of prostaglandins. And they're usually used for mild to moderate pain. So let's talk a little bit about how the underlying action of aspirins and NSAIDs work. Really, it's looking at COX, and we're looking at COX-1 and COX-2. So COX-1 is responsible for a lot of the physiological functions, gastric protection. So part of that is increased mucus production and bicarb secretion, maintaining blood flow within the gastric area. Vasodilation. So not just vasodilation in general, but it also, importantly, you have vasodilation in the kidneys, and it's also responsible for helping with platelet aggregation. COX-2 is mostly used to foster inflammation or inflammatory processes. So here you also have vasodilation, and it's also responsible for pain, and it can also promote colorectal cancer promotion. So, in looking at aspirin, aspirin irreversibly inhibits both COX-1 and COX-2 for the life of the drug. It's over the counter, okay? So, that's what makes it different than first generation NSAIDs like ibuprofen, which reversibly inhibits both COX-1 and COX-2. So ibuprofen, so forth. And second generation NSAIDs only reversibly inhibit COX-2. And remember, COX-2 inhibitors, Celoxib or Celebrex, is only, you can get that only over the counter. So if we look at aspirin itself, it's used for mild to moderate pain. We use it for inflammatory disorders, dysmenorrhea, osteoarthritis. It can be used with or formulated with other opioids. So you'll notice it's formulated with, for instance, codeine. It can be used for fevers, because remember, with a fever, there's a release of interleukin-1, which leads to the formation of prostaglandins, which lead to fever, so aspirin can help with that process. It's also an anti-inflammatory drug, so it blocks prostaglandins responsible for inflammation. Remember, that's your COX-2. So prostaglandins, can actually lead to pain in that inflammatory type pain. It's also used as an antiplatelet agent. So, it's a daily maintenance dose for those with cardiac history. They'll get a small dose of aspirin. It's used for platelet aggregation, so prevent platelet aggregation. So the important thing here is that with aspirin, it inhibits platelet aggregation for the life of the platelet. And we use it due to its inhibitory factors related to platelet aggregation for prevention of MI and stroke and diabetes. Let's start with the most common. If anyone's allergic to aspirin, they shouldn't be taking it. If they have a history of any GI ulcers, they shouldn't be taking aspirin or NSAIDs. Because remember, COX-1 protects the gut. So if they already have an issue, it's going to reduce those protective factors. Number 3, if they have any sort of renal dysfunction, we don't want to give them something that's going to further compromise their kidneys. Remember, COX-1 maintains renal vasodilation. If you inhibit it, you're going to make it worse. And it's even going to be further compounded with someone who has renal dysfunction. Bleeding disorders. Remember, both aspirin and NSAIDs actually allow for platelet aggregation. By inhibiting this process, you're going to cause further bleeding. So it shouldn't be used in people with bleeding disorders. Pregnancy. We do not use aspirin or NSAIDs with pregnancy. It has a lot of issues. It's been associated with low birth weight, stillbirth, renal toxicity, hemorrhage in preterm infants. It's also been known to cross the placenta, and it inhibits prostaglandin synthesis, so it might cause premature closure of the ductus arteriosus. So multiple things with pregnancy. Shouldn't use aspirin and NSAIDs with pregnancy. Drug interactions. These, the first set makes sense, right? Anything that's going to cause bleeding, you add aspirin and NSAIDs, that's going to reduce platelet aggregation, is going to cause more bleeding. Glucocorticoids, however, it's a different situation here. So here you have someone who, if they already have ulceration, glucocorticoids can cause ulceration or problems with the GI tract. Add on aspirin and NSAIDs, it can further make GI issues worse. So, adverse effects make sense. I've sort of already hit some of them. GI, it can cause GI distress, heartburn, nausea, and it can cause bleeding and ulceration because remember, it reduces those protective effects. It can cause bleeding for some of the things I just mentioned. It does cause renal impairment. Remember, by inhibiting COX-1, it can decrease the blood flow through the kidneys. Okay? It can also cause this thing called Reye syndrome. Reye syndrome happens when a child takes aspirin under the age of 12. It's associated the child would also have flu or the chicken pox. Add aspirin, and it's fatal in about 30 to 40% of the cases. So in these kids, they show up with encephalopathy and liver dysfunction, and it can be mortal. So we don't give aspirin to anyone under the age of 12. It can cause adverse effects during pregnancy. Remember, I said it crossed the placenta and caused all sorts of problems with the baby. You can have hypersensitivity with aspirin, and it can cause salicylism. Salicylism is a condition where you take too much aspirin. It's sort of dose limiting, and you can have tinnitus, sweating, headache, and dizziness. If you have salicylism and that's progressed, or you've taken even more, you can have acute poisoning. Signs and symptoms here: you have respiratory alkalosis, which can lead to respiratory depression. You can have acidosis, hyperthermia, sweating, dehydration, electrolyte imbalance, coma, and death. Supportive care. Anyone who has aspirin poisoning, here's what we do. Remember, it's an irreversible COX inhibitor, so we want to pump their stomach, give them charcoal to bind to any aspirin that still may not be absorbed. They get cooling blankets, because remember, they're hyperthermic, fluids, and bicarb IV. So it's all supportive care until that aspirin is eliminated from their system. Ibuprofen. Just as a reminder, it reversibly inhibits COX-1 and COX-2, unlike aspirin, which irreversibly inhibits COX-1 and COX-2. Therapeutic action here, it is used for anything that has inflammation causing pain and or fever. So adverse effects, again, just like aspirin, it can, because it reduces those protective factors, it can lead to ulceration and perforation of the GI tract. It can also cause renal impairment by vasoconstriction of the renal vessels. If you have a allergic reaction to aspirin, you can have hypersensitivity to ibuprofen. Adverse effects with ibuprofen are the same as with aspirin. So it crosses the placenta, can cause all sorts of bad things with the baby. Now, here's something unique. So it has a cardiovascular risk. How is that? Remember, it reversibly inhibits COX-1 and COX-2. So there is some, it inhibits platelet aggregation, but it can also cause vasoconstriction in cardiac vessels. So there is some risk. And Stevens-Johnson syndrome. So Stevens-Johnson syndrome is characterized by a rash that's pretty lethal. Okay, Celebrex. So Celebrex selectively inhibits COX-2. We use this for types of arthritis and acute pain. So, in looking at adverse effects for Celebrex, you're like, what? It causes GI issues? I thought it only affected COX-2. So, in essence, it is safer than other traditional NSAIDs like ibuprofen, but studies have been shown that there still are some detectable ulcers in patients taking Celebrex. So, even though the risk is a lot smaller, there are some still GI effects with COX-2 inhibitors. And the method is not completely known, and they recommend taking PPI. There is cardiovascular risk. So remember, with Celebrex, it doesn't inhibit platelet aggregation, but still causes vasoconstriction. So this is a problem, especially with those that might have an underlying cardiovascular history. So this can actually increase your risk for MI. That's something you really need to know about these patients if they're going to be taking Celebrex. And it can cause some renal impairment, just like I mentioned about the GI effects. It can especially cause renal impairment with anyone who has underlying disease or kidney disease. If you have hypersensitivity to aspirin or sulfonamides, you may be allergic to Celebrex. And there's definitely issues in pregnancy in that it can cause premature closure of the ductus arteriosus. So acetaminophen. Acetaminophen inhibits COX in the CNS only. So unlike all of its other predecessors that worked all throughout the body, acetaminophen only works in the head. So we use this for analgesic and antipyretic, but we don't use it for inflammatory processes. The max dose is 4,000 milligrams per day, And outpatient, we recommend that people outside at home have a max dose of 3,000 milligrams per day. Ibuprofen, as recommended by the National Pain Society, has a max dose of 3,200 milligrams per day. So unlike the other drugs where we don't really have you memorize things, the max dosage for acetaminophen is something you do need to memorize. Adverse effects. It's super well tolerated. In fact, I think it's pregnancy category B, which I know the categories are going away, but that means it's pretty good. I think water is pregnancy category B in good areas. However, you could have an anaphylactic reaction with acetaminophen. And if you do have any sort of skin reactions, you stop it immediately. The big thing with acetaminophen, and should be bolded, is hepatotoxicity. For doses greater than 4 grams per day, this can happen. And in some literature, they've mentioned that acetaminophen poisoning is the reason for a lot of transplants here in the United States. So if you have acetaminophen overdosage, it's pretty clear. They'll have GI symptoms. And then after 24 hours, you might have right upper quadrant pain and manifest with other signs of liver toxicity. And the progression is seen here. Not that I'm going to test you, but anyone who has acute overdosage, they need to be treated as possible. The antidote for Tylenol overdosage happens to be acetylcysteine or Mucomyst. It should be administered as soon as possible. It's considered to be useful up until 24 hours of acute ingestion. So timing of when someone ingested this is really very important. With acetaminophen, it's really important you educate people about liver toxicity risk, and that they need to know that Tylenol or acetaminophen can come in many different settings. Since this is an over-the-counter drug, it can be in cold medicine, and that's why we recommend a max dosage of 3,000 milligrams per day in community setting. Anything else that can impact the liver, so alcohol, they shouldn't have, if they're drinking alcohol at home, they shouldn't take more than 2,000 milligrams per day. Anyone with pre-existing liver disease, we want to avoid use in. And knowing that if someone's taking a lot of Tylenol and they have other drugs that also cause liver damage, as a nurse you're definitely going to watch that. So like the statins are a good example. And patients need to know what other products have acetaminophen in them. So we added the centrally acting non-opioids. So unlike the NSAIDs, these are different, okay? They don't work in COX, but they do have the abuse potential, and they work much differently. So even though they're non-opioids, they don't have the same basic principles. So there is no ceiling effect with these, and there is abuse potential. So let's move forward. We're going to talk about tramadol and clonidine. So tramadol has weak agonist activity at mu receptors. That's where morphine works, okay? Instead, its main action is it blocks uptake norepinephrine serotonin, activating the spinal inhibition of pain. So norepinephrine and serotonin are both monoamine neurotransmitters, and they're mediators in the pain pathway. Serotonin in particular is associated with happiness, well-being. Serotonin can be found in lots of different places, like the brain, the bowels, and with platelets, and it has a role with vasoconstriction of smooth muscles. As its role with well-being and happiness, serotonin can be found in some drugs like ecstasy and LSD, where there's high levels of serotonin. And serotonin is released by platelets, causing vasoconstriction and reduced blood flow and clot formation. It's a precursor to melatonin, so it affects the sleep-wake cycle. It has a role in appetite, so it can actually help to reduce appetite while eating, and has lots of other activity. For instance, when you're nauseated, the gut releases serotonin, increasing peristalsis, leading to diarrhea and nausea. And serotonin inhibits sexual activity. So serotonin is a really important neurotransmitter. Tramadol as a drug is used for moderate to moderately severe pain. It's not considered any more effective than codeine with aspirin. It's considered less effective than morphine. Morphine's for severe pain. We're going to talk about it. Usually have relief after an hour of oral dosing. Peaks in 2 hours and duration 6 hours. That's just FYI for you. So tramadol adverse effects are kind of rare, even though this drug is a controlled substance. You can have respiratory depression minimally at recommended doses, and you don't need to know the doses. Commonly, they can be sedated. Hence, if they're overly sedated or they have too much, they can have respiratory depression, have dizziness, headache, dry mouth, and constipation. Remember, tramadol affects serotonin receptors in the gut. Anyone who has a history of epilepsy, they should avoid this drug. The big risk with tramadol happens to be drug-drug interactions. So anything else that can cause CNS depression, like alcohol, the combination can be fatal. Hence, it can be a vehicle for suicide if taking tramadol. Other things, remember, its main effect is through affecting levels of norepinephrine and serotonin. So you can have hypertensive crisis if, that's where the patient exhibits tachycardia and high blood pressure, if combined with other drugs that also inhibit the uptake of norepinephrine, making it more available. So MAO inhibitors can cause hypertensive crisis when combined with tramadol. It also, one of its main actions is by affecting serotonin. So other things that might also increase the availability of serotonin in the body, like SSRIs, or other antidepressants like tricyclics, MAO inhibitors, and the triptans, which we're going to talk about a little bit later in this module. They all increase the levels of serotonin. So you can have this thing called serotonin syndrome. Patient that exhibits this will be sweating, they'll have a high fever. The fever is the key thing. High fever, rapid heart rate, high blood pressure, and confusion. So in taking care of a patient who's on tramadol, what do? Well, it's a controlled substance. Even though abuse potential is low, we're still going to be looking for abuse related to this drug, and it's monitored. It can be a vehicle for suicide, so you want to prevent this patient from taking anything else that can be a CNS depressant. And you're going to monitor for drug-drug interactions, hypertensive crisis, and serotonin syndrome. The other drug that's a centrally acting non-opioid, but not an NSAID, doesn't affect COX, happens to be clonidine. We talked about clonidine earlier in the semester. It binds to alpha-2 receptors in the spinal cord or centrally, and it blocks the pain pathway from the periphery to the brain. So we use this for cancer pain that's not relieved by opioids, neuropathic pain, and it can be quite useful. This drug does have an abuse potential, just like tramadol. Adverse effects, though, you should be aware of, right? Clonidine's also an antihypertensive medication, so it can cause hypotension, it can cause bradycardia, and it can cause rebound hypertension after abrupt stoppage. So you don't want to abruptly stop someone. This drug can be given as a patch, so you have patch issues related to it. Common adverse effects happen to be dry mouth. It can cause sedation, just like tramadol, dizziness, anxiety, and maybe even depression. big thing with this, nursing implications. You want to monitor vital signs, avoid abrupt stoppage, and be aware of any sort of patch application issues as you have been throughout the semester.